it. You don't have to really push hard. Like you can't get your eyes away from it. That's the basic kind of thing tip. And listen to the examiner because there would be some kind of clue, as I always tell you, that it's the age or I mean the symptoms are usually similar in kind of MSK, but they could be the pertinent clue like unwell or the, particularly age. I think that's very important when it comes to musculoskeletal and pathologies, particularly bone lesions and stuff like that. And it, obviously, I mean, we don't show you like bound or obvious things. I mean, that's not the point. The point is your approach, and that's why there's usually common pathologies which can be atypical in location or presentation. Uh, and always look at the review areas, whether it's an MRI. For MRI, you can always ask for a scout film because that might be something hiding there, or it could be the first or the last slice of a CT scan. And then obviously in the plain films, you have review areas for each thing. Like always look at the sacrum on a pelvic radiograph, acetabulum, edges of the film, proximal femora in the pelvic X-ray, or X-ray, you know, your review areas, clavicles and diaphragms below the heart and paraspinal, these kind of things. So always, this is just like replicating your day-to-day practice, right? And then it's important that you should earn the other view, right? So whatever is shown, just describe it and say that this is as much as I can describe on this. Connected to something else now, so uh, it's you guys. Okay, all right, thank you. So so this is, I think, one thing which I was just talking about, that yeah, this is exam is all about replicating your day-to-day clinical practice. You have to detect, that's the first thing, but the most important thing is you have to describe it. That's what we usually do in the body of our report. We don't kind of jump to the diagnosis straight away, right? So you have to describe. That's where you you execute your skills as a radiologist, and that's what they are judging you on. So if you jump to diagnosis without describing it, that's going to cost you the case. I mean, they might kind of score you very low, or even you can fail it, even having a correct answer. And obviously, it's something which is important to communicate to the clinical team. You have to demonstrate that, and you all know this thing. So the aim is to aim about 6 and 7. 8 is probably, I mean, you might be lucky if you score 8. If you're really good at one case, fair enough. But the aim is to do as many 6 and 7s so that by the end it averages out to 6, and then you are kind of a clear pass. All right, okay, I'm just going to close this and let me share my other screen for the cases now. So I do, hope this is going to work. Share. Right, continue. So I've got the first candidate there, please. Yeah. You guys, you can hear me, please?
Yes, I can hear you.
Right. Okay, lovely. So I have got this 60-year-old, and he presented with a swollen, painful ankle.
16 or 60, sir?
60.
60. Okay. So I've been provided with the AP view of the 60-year-old patient um, of the ankle and the lower leg, and I can see that um, that there is a kind of aggressive looking pathology involving the visualized portions of the tibia as well as fibula, um, till the articular, almost till the articular surface, but not involving the talus and rest of the visualized bones. The bones look to be mm, um, the bones appear to show permeative kind of destruction with with a pathological fracture, in fact, at the lower end of the tibia, because there seems to be cortical break at that site, uh, seen at the medial aspect. So, considering considering multiple sites of involvement, I mean the involvement of two bones on this X-ray and in an elderly patient, um, I will. I'm thinking on the lines of some aggressive process, um, like
Aggressive process like.
maybe an infective pathology. Although I believe that since both the bones are involved, um, that usually does not explain this well, but that might be a consideration. And
Mhm.
uh, besides that, I'm thinking on the lines of although infection, I believe it to be less likely, considering that there are two bones which are involved and the joint is spared. It's not involving the joint per se on the X-ray. Uh, and besides that, I can think of some neoplastic process, which is kind of a marrow infiltrative pathology, diffusely involving the marrow. Um,
Okay, like infiltrative pathology, like.
um, like metastasis or lymphoma.
Okay, that's the. This is the lateral view.
Okay.
Does it add to anything that you have said?
No, I don't think it adds much because, like, I mean, the rest of the bones which I can see in this view, they appear to be normal, and only those bones which I saw in the AP projection, they are the ones which are affected. And there is in fact a pathological fracture which is obvious on this lateral projection.
Anything else that's obvious on this one?
Um,
You couldn't appreciate much on the AP video.
there's not much of soft tissue prominence. Um,
Wait, say it again.
there's not much of soft tissue prominence which I can see on this.
Are you sure?
Um, Sorry,
Where are
sir.
you looking? Where are you looking for soft tissue on the lateral radius?
Um, I'm looking at the anterior as well as the posterior aspect, and I can't see any.
Okay.
Yes, yeah, I can see some soft tissue at the site of the fracture, some prominent soft tissue there at the fracture site.
Right. Okay.
Yeah,
So if you are reporting this, you're doing a ED shift, and this patient is on the ED list. What's the next step you're going to do?
like to go for MRI for further assessment.
You'll do MRI. Let's say it's at 2 o'clock in the morning.
Okay, so
Before reporting it, would you look at something else?
um, uh, I would like to look at the previous X-rays if available.
Okay. I've got a previous one from second. I have got a previous X-ray from 2 months back. What do you see there, or is it normal?
Okay, these skygrams, um, I believe they again show similar changes, although to a much lesser degree. I can see such
Mhm.
appearances in the
So this is like
malleus.
2 months back,
Yeah, so the changes are there probably, but to a very lesser extent. And
right?
uh, yeah.
Right.
Okay,
So,
and
okay.
yeah, I
Anything
can
else
see.
you would like to look at before? Oh, yeah. Mhm.
Yeah, I can
Sorry,
see
I
that.
didn't.
Yeah, there's some destruction at the lateral aspect of the lower tibia as well, and yeah, and some heterogeneous appearance of the tibia in the upper portion of the visualized tibia. So the changes were there in the previous diagrams as well, and but they are much more pronounced in the
Okay, so let's
present.
go back to yes. Okay, right. So you would just do an MR, yeah?
Yeah.
Okay. Is there any other thing you can think about that would be a cheaper test to reach the diagnosis? Because in a 60-year-old, you're thinking about, you said infection or
And
metastases, yeah?
I can do an ultrasound because there's some soft tissue prominence in the lower portion of the this
How is it,
to look for
how is it going to add to what you already,
look for some fluid collections, or which was leading to some soft tissue prominence in the lower portion of the leg.
right? Okay. So metastases or primary bone tumor, that would be the next question.
Um, um, Considering that both the bones are involved, I believe that it should that favors a primary bone. Sorry, metastasis more than a primary bone tumor.
Right. Metastases from?
Um, there are patchy sclerotic areas as well. So if the patient is a male, I'll think about prostate. Or
Yeah, he's a man.
sorry, sir.
Yeah, I mean, yeah. I said 60-year-old man. So yeah,
Yeah.
okay.
So
Oh,
I'd
but
like to
this
know
is
about.
it typical? I mean, obviously you can have lytic metastases with prostate as well, but that's quite unusual, isn't it?
Yeah.
Which common cancers can you think of that can give you this permeative and not too rapidly progressive bone destruction?
Um, Considering that there are mixed lytic as well as sclerotic areas, it can be a lung malignancy as well, or it can be a TCC of the bladder, urinary bladder, prostate malignancy. I can think of. Although lytic areas they don't go well with the prostate malignancies. Um,
So if
so
you're
I like
thinking
to.
about thinking about a lung cancer, what's the next step then?
Yeah, I can consider lung malignancies as well because they can lead to lytic as well as sclerotic metastasis.
Right. So what's the cheap test that you can do? You can think about to exclude malignancy, a lung
Um,
cancer.
just X-ray. Yeah, I can see here on this
What
chest
is it?
X-ray of this patient, I can see a round, rounded density, which shows some irregular margins in the right mid lung zone, and um, I don't see any obvious bone destruction of the underlying bones in this region. So this could be the primary lung cancer, which might have led to the metastasis in the leg bones. So considering
Okay.
this, I'd like to get the patient further evaluated for rest of the skeletal survey.
Okay. All right. So I'll show you the MR as well. I know. I mean, whenever you're shown a bone tumor or a bone lesion, you always rightly kind of jump or think about getting an MRI. But if you're thinking about metastases, I think it's a good practice. I mean, that's what we do always, isn't it? If you see something like that, the first thing you see is there a chest X-ray there, or is there a history of breast cancer? With common things common, you see. So
Yes.
the cheapest test that you can offer at odd hours, I mean, you can just get a chest X-ray if you're a smoker or whatever. But this one, I mean, look at, I mean, MRI is just gonna kind of delineate the normal and the abnormal bone. But this is, it just shows you,
Yeah.
or you can see. I mean, you want to describe the findings there just for your practice.
Yeah. On these coronal sections of this patient, MRIT one-weighted images, they show altered signal intensity lesion in the visualized portions of the tibia as well as fibula, and it seems to be sparing the ankle joint. Um, yeah,
So
the
I mean,
tendons.
I think I mean, let me just interject here. I mean, whenever you, I mean, the idea is whenever you see something that kind of crosses two, that involves two contiguous bone, you always think about infection, right?
Yeah.
But there are aggressive kind of malignancies as well, metastases that that don't respect the boundaries. I mean, you can see that it's getting out of the tibia, and it's probably, it could be that they have like the both bones were seated separately, and somehow the tumor grew and then it just coalesced, right?
Yeah.
Or it could be started at one and got to the other thing. So having two bones makes you think about infection, but metastases or primary bone tumors can do the same as well if they are really aggressive, right?
Yes.
So, and then like you said, the ankle is spared, but I mean, I mean, when you catch a process, I mean, it can be spared. But yeah, in a 60-year-old, you could, like you said, lymphoma, that was a good thought. Metastases or myeloma, I mean, because it's, that again can do these things, right? Okay, great. So always the moral is when you're thinking about metastases, start with a chest X-ray. That's the cheapest test. I mean, you can just, you can guide the clinician into the right direction by doing just a common approach. Obviously, they will need an MR. I mean, just to kind of plan radiotherapy or just to see the extent of the disease and if it's a surgical candidate for surgical planning. But for metastases, and you have to look at the primary and, chest X-ray is a very simple test which may direct you in the right direction. Right. Okay, great. Okay, let me put the next case for you then. Right. Okay. Let's see. One second. I know you guys can see the names there, but it's just like my screen is. Okay, let me. Right. Um, there's that. So I have got a 39-year-old, and I'm going to show you this pelvic MR, and he's got severe hip pain. All right. Okay.
Okay.
I'll just kind of start from I'll start from here, and I'll just try to scroll slowly. Just bear with me. That's the back. Let's come to the front. There's a coronal stir, right? Coming forward. I stop there then. Do you see anything obvious? You want to comment to that?
Yeah, yeah, I can see that there is start hyperintense signal in the lower portion of the right iliac blade. And besides that, I can also see some edema there in the adjoining gluteal muscles. Um, the rest
Okay.
of the visualized bones show preserved marrow signal intensity, and I don't see any other
Let
signal I
me
can find.
do. All right. Okay. This is like the axial now. So let's start with the axial. I'll come down and then I'll let you all have a look, and then you can start thinking about it. Right. I'll stop there, and I want you to describe what you see now.
Yeah, so I've been provided with the star axial images of the same patient, and here again I can see um, that the low portion of the right iliac bone shows star hyperintense signal um, with surrounding edematous
Yeah.
changes,
Mhm.
and and
You see,
yeah, I can see something here as well. Um, Maybe there is some fracture or something like that. So can I have a look at the T1 weighted images?
so, okay, you've got a dedicated right head going cranially. Um, okay. What do you want to comment about the T1 weighted
Yeah.
sequence?
Um, yeah, I can see that there is altered marrow signal, and one of the focal areas is looking intensely hypointense, both on T1 as well as the stud images. Um, yeah, this area
Okay, let
is
let me get you a sagittal probably to give you a better idea. Okay, so
okay.
let's put this sagittal. I know it's a bit probably I should put both of them together, but okay, this is the right hip sagittal PD pad suppressed. I'm doing a bit fast, but let's just do it slowly now. What about if I stop there? Want to
Okay.
describe? Give me your impression. What you think is happening?
Yeah. There is this markedly hypointense looking area affecting the this alic bone with surrounding inhibitors changes. So I believe that this could be a small tumor, or although the patient is young, but since it's
Okay, okay.
looks like
Let me just let me help you here. Which
yeah,
part of iliac bone is the epicenter of the problem?
um, maybe the anterior inferior iliac spine.
Okay,
Uh,
good. All right, let me put them together then. So, okay, let's get. Uh, I'll put the
I would like to
axial.
correlate my findings in this case with these X-rays also if they are available,
Right. Why do you need to see the X-ray?
because because the patient is young, so I'd like
Mhm.
to exclude some avulsion injuries or
Okay, well, an injury of what? Which tendon are we talking about? Which is this
since it
tendon?
seems to be anterior inferior iliac spine, so it
Mhm.
could be rectus femoris.
Right. Okay, so you want to see the X-ray, right?
Yeah,
Oh, let's see if I have got an X-ray for you. We're lucky we have got an X-ray. Right. From that. So that's the X-ray we have.
yeah. So yeah, there is some a bone fragment which seems to have been avulsed from the inferior iliac spine. So, so this could be an
But there's no history of trauma.
okay. So in that case, could be a small osteochondroma
Okay. Let's go
pedagogy to
back to the
correlate that.
let's go back to the MR. I have got the axial back. What is against osteochondroma here?
I don't see a cartilage cap over there.
What is this? You said there's a hypointense
So
fluid.
that hypertense was that ossified lesion which I was seeing on X-ray. So appearing black on both T1 as well as stud
Do you think
images.
this is
Intense.
ossified?
Uh,
How can we confirm this is ossified or not?
um,
Okay. By doing a CT, right?
yeah,
Okay. I'll put the CT up for you. do you think? Is it ossified
So
or calcified or both?
this, sir, this can be because
Yeah.
my till now I'm primarily thinking on lines of two differentials, which was an avulsion injury or a small cartilaginous tumor. Yeah.
Okay.
So
Okay. If we put the tumor on the shelf for the time being, I mean, emulsion injury is a possibility. Yes, it's not typical of an emulsion injury,
yeah.
but it could be the patient might have an injury and he doesn't remember. But which other? But if we say he's got severe sudden onset of atraumatic severe pain and he can't, then which other neoplastic think about?
So, so if you can repeat, like the voice was not clear. Yeah. Hello.
What I'm saying is that, yeah, you can hear me now.
Yeah.
What I'm saying is that if let's let's forget the tumor for the time being.
Okay.
You said a traumatic emulsion injury. Okay, that's a possibility. But what other non-neoplastic pathology you can think about that can give you severe pain at a tendon insertion?
Um. Um. Enthesitis.
Okay, enthesitis. Yes. All right. Okay. But what's that? I mean, how often do you see with an enthesitis this calcification? Okay. If I show you a shoulder X-ray
Yeah.
with this kind of a amorphous calcification, what will be your diagnosis?
Um. Um. That usually is seen with the supraspinatus tendon near the insertion site,
Yeah. And if you got
or
calcification there, it can
Hi,
cause
Doctor. We
acute.
can't see the screen. The images aren't on the screen.
But now,
yeah, yeah. And now I
yeah,
can see. Yeah.
now,
So the X-ray is visible right now. Yeah.
yeah. Okay, I've just clicked on that. Yeah.
Okay. So
So if you see it in the shoulder, what do you call it?
calcific tendinitis.
Yeah. Okay. So why it can't be calcific tendinitis of the rectus femoris tendon? I mean, that is
Yeah. Yeah. It seems to
plausible.
be. Yeah. It seems to be taking the course of the tendon as
A lot of
well.
inflammation. Yeah. So I mean, you see, the epicenter of it is in the tendon, all right. Okay, this calcification on MR, and then part of it has eroded into the bone, and it has caused a lot of inflammatory edema around it.
Yeah.
Right?
Yeah.
I mean, I know it's an odd location, but if you're thinking about that,
Yeah.
uh, but obviously I mean, you might think about some aggressive process. It could be infection or something, which is unlikely though. The patient is well otherwise.
Yeah.
How could you be? I mean, how can you cover yourself that this is calcific tendinitis and nothing sinister?
Mm,
You're not going to jump on biopsy straight away.
yeah. I think yeah we can
So
go
you're
for a
thinking about a B9,
CT.
B9 process
We can go for a
already
CT
done.
as well. We can go for.
Mhm.
We
What
can
about
proceed.
getting MR in 6 weeks?
Sorry, sir. Hello.
What about getting a follow-up MRI in 6 weeks?
Yeah, that can also be done. Yeah, to see the progression
Okay.
and the growth. Yeah.
So let me show you this 6 weeks post. zero. But what has happened to the process? Is it better or worse? Let me put the other MR with it so that we can look at it side by side. So this was like 6 weeks ago, okay, and this is now. So has it got better or worse?
So the present one is on the left side.
Yeah, this is the present one, and this was which I've shown you, the
So
first one.
this seems to, yeah, this seems to have improved now that edema has settled a bit.
Yeah, so that's quite reassuring, isn't it?
Yeah, yeah, yeah,
And even that calcification is much less now. You see,
yeah,
here you come here. The guy just took anti-inflammatory medication, and within 4 weeks, his pain was back like very little pain. This was
yeah,
calcification. Now that calcification just absorbed itself.
yeah.
So yeah, this was a case of calcific tendinitis,
Okay, sir.
rectus femoris.
Yeah,
So think about non-neoplastic conditions as well that can look very aggressive on MR because MR is very sensitive at picking up inflammatory marrow edema. All right.
yeah,
Okay.
yeah.
Any question about that?
No, sir.
All right. Okay. Okay. I'll show you the next case then. Just bear with me.
But
Uh,
can we keep such kind of differentials, which I mentioned, like in
yeah. I
cases?
think so. I mean they were. I think your osteoma. I think these are the other two. I think I would probably put. Uh, Okay, let's go to this case now. So he's a 25-year-old and he presented to emergency with atraumatic ankle pain.
Okay. So I've been provided with the X-ray ankle of this patient, 25-year-old patient, right ankle view, and here I can see that there is some abnormal looking lucency in the lateral malleolus of the fibula, and um, besides that, I'm also suspicious for some lucent area in the tibial metaphysis as well, lower tibial metaphysis, some ill-defined rounded area. So besides that, the visualized talus and rest of the bones, they look apparently normal to me. So can I have another view, orthogonal view for this patient? Yeah, again, I can see that that area is although overlapping with the fibula, but there is some lucency which is there, abnormal looking lucency, with sorry, in the lower tibial metaphysis. And so can I go back on the frontal projection? Yeah. So, and it has got a wider zone of transition. The margins are not very well defined. So I believe that this is an aggressive process. And considering the patient is young, I would like to keep infection as a possibility considering the metaphysis is involved. And I would like to inquire about the history of fever or any previous x-rays if they have, if they're available with the patient, and other blood markers as well if they're pointing.
Patient is well, and the patient is well, and this is the first X-ray, first presentation.
Patient is well. Okay, okay, okay. Otherwise, okay. So, so then I believe that infection appears to be less likely. Uh,
Mhm.
but I would like to definitely get the patient, compare this with the previous skygrams if they're available, or if in case they are not available, I'd like to proceed with further evaluation of this patient for the assessment of better
What's
assessment
your
of this.
differential apart?
Um,
But
um, yeah, I would like to keep infective process as I mentioned in the differential, considering the patient is young, and besides that, um, it can be a neoplastic process also, but considering the patient is young, I would like to keep it lower in my differential. Uh,
Right? Why is that? You think it's an aggressive process, but
Yeah,
it
because I
can,
don't see that it is well circumscribed, and particularly superiorly, the zone of transition is not very discernible. So
what does that what does that imply?
that it's an aggressive process, and
Right.
um,
Which aggressive process apart from infection you can think about in a 25-year-old?
25-year-old patient, think I can think of lymphoma, or I can think of histiocytosis. Um
Or
or Ewing's is lower down because there's not much of soft tissue in this case. And Ewing sarcoma, I think, is a more early age group, and as a patient is 25. So
so what would you put in your report then?
um,
What will you
I
tell
would
the
like to
community?
mention, my possible differentials, and I would like to see the previous diagrams in case they're available and proceed. If not available, then discuss the case with the referring team and proceed with further assessment with the MRI for further characterization of this lesion.
Yeah, okay. So let's look at this. The patient had MRI a few weeks later. Um, I'm going to start with the coronal stuff.
Uh,
You want
yes,
to
I've
see a
been
T1
so
with it,
provided.
or you want to comment on
Yeah,
this?
I would like to see the T1 also before I can, yeah, before I like to proceed with.
Okay, so that's the front going back.
Okay,
I keep that for you.
yeah.
So
So can I have a look at the T2 also and then PDFS again?
you describe what you see here first, please.
And in case diffusion is available, because it's looking quite bright to me on
That's
these
fine.
stud
You're not.
images. So I would like to, sorry, sir.
I want you to describe the findings on this T1 weighted sequences first,
So
please.
on these T1 weighted images, I can see that there is an altered signal intensity lesion in the lower tibia, predominantly involving the metaphysis as well as the epiphysis, involving the medial malleolus portion of it, but it doesn't seem to be involving the joint, and yeah, and almost reaching up to the articular surface, but not involving the joint space, although, and the rest of the bones are also looking normal.
This is the
And yeah, on the corresponding stir images, I can see that um, that the lesion appears heterogeneously hyperintense, and again, without involving the joint space or rest of the bones, and predominantly involving the lower portion of the tibia only.
okay. Let me show you the post contrast. This is the post
Okay.
contrast cycle T1 first. So,
So I've been provided with the sagittal post-contrast images of the same patient.
yeah, describe what you say.
On these images, I can see that the lesion predominantly shows peripheral enhancement. So, and there is some
That's
patchy
fine.
enhancement also seen in the adjoining areas, which were probably representing edema, looking like edema on the stir images. So considering the site
Okay, let's
and the peripheral,
let's
sorry, sir.
well, sorry. Let's look at the axial as well, and then you can conclude.
Okay,
Yeah.
okay,
This is axial post contrast. All right. Okay.
okay.
That for you. Oh, yeah. Okay. You want to add something to what you've said, or you want to conclude?
Yeah, I can see a lot of inflammatory changes in the surrounding region of this area, abnormal central area, which is peripherally enhancing. And I don't see any obvious sinus
You
tract.
you asked for diffusion, didn't you?
Yeah, if that is available, yeah.
So how is that going to help you?
Since I'm thinking on the lines of abscess and the imaging features till now are also pointing towards abscess to me because there is abnormally T2 bright area in the tibial metaphyseal region and showing peripheral enhancement with a lot of inflammatory changes in the surrounding areas. So I believe that this is an infective etiology only, and the central area, I just
Mhm.
want to confirm on diffusion whether it is truly restricting or not, because that will
Okay, so I'm
further.
showing you diffusion. This is your you can see my arrow.
Yeah, I can see the area.
You can see the mouse. Yeah.
Yeah, but yeah,
Hello.
so yeah, yes, sir.
You can see.
Yeah, but I don't see the mouse, the mouse moving. It is there on the left side of the image. Yeah, it seems to be frozen to me. Hello.
Yeah, it looks like Dr. Asad has another issue with the connection. He will get back soon. Please bear with us. Thank you.
Hello again.
Yes, sir.
I think I've lost. I mean, my the connection is quite precarious here. I don't know why. But my apologies for that. I think I lost you there, but I'll just put this on again. Uh, right. You can see the screen, yeah?
Yes, sir.
Okay, so this is, let me minimize myself. So yeah, so this is your DWI and this is ADC. So I'll scroll for all of you. So that's the level of the ankle. So we're going up.
So we can see only one image. The
You can see only one image.
yeah,
Okay, so what do I go ahead? Both. Share two. Now you can see both.
yeah,
All right. Okay. So this is so on the left of the screen. This is your DWI. This is your ADC on the right of the screen.
yes, sir.
So what do you think? You want to comment on what you're saying?
Yeah, I can see that there is diffusion restriction in the affected regions because they are looking hyperintense on the ADC maps. So so with these
Right.
findings, I believe that this is a case of infective etiology, like
Okay.
osteomyelitis with
But how short?
with sepsis formation. Yeah,
Okay. So patient is where,
it can be a cold abscess. It can be
or you would just stick.
yeah, because there's
Okay.
profound changes in the.
Cold abscess. Yes. All right. What else?
Sorry, sir. Hello.
No, I can't hear you. You finish what you're saying. Right? Yes, hello, I can hear you.
Yes, sir. Yeah, I
Yeah,
believe
please,
that
yeah.
it can be a cold abscess, but I don't think that that it's a neoplastic etiology, considering the amount of inflammation which I'm seeing on the MRI.
Okay, right. I think I'm going to finish here, but I'll just show you this T1, all right? Okay.
Okay, okay.
So on this T1, you think this looks like infection to you or tumor?
Mm, so I can't comment on this, like whether
Okay,
it's
so what will the next step? You will tell them just treat it with antibiotics, or what's the next step then?
um, I would like to see the previous radiographs if they are available, or
There's no
we can.
previous. This is all what we have.
Okay, so patient's age was 25, I think.
Yes, yes.
Okay, so I think we
How
can.
can you be 100% sure? How can we come out of this confusion or this conundrum that this is infection or not?
We can look at the blood picture of the
But I
patient.
told
We
you that's
can have.
normal.
Okay, so mm, we can refer the patient to a bone center if required for a biopsy then.
Right. You're a bit shaky about it. Why is that? You think that's not the right thing to
No,
do?
since no, not like that, but since it's an invasive procedure and painful procedure, so which is why I just wanted to keep it lower down.
So, do you know of any tumor? I mean, any tumor that can restrict?
Um, Lymphomas can restrict.
Yeah. Okay. So yeah. So this could be lymphoma, isn't it? Or
Yeah, it
it
can be
it could be
autoimmune.
any cellular tumor,
Yeah,
right?
yeah,
And so yeah, so we biopsied it. It came back as a round blue cell tumor with Ewing like cytochemistry. So yeah, it was immunohistochemistry. This was Ewing sarcoma.
okay,
So you see, I mean, the thing is, not everything that restricts just mean it's a rich cellular lesion, right? Okay, it could be medulloblastoma in the brain, right? It could be lymphoma anywhere. It could be pus, even hematomas when they are like when the blood cells are still not hemolyzed, they can restrict. Okay, so don't
okay.
and pus as we know. So but this is if you see here, it's not a typical. If it's pus, then it should restrict like a big round lump, isn't it?
Yeah,
So the
yeah,
fluid bit is not restricting, it's the rim which is restricting. That
yeah,
has to make you think that it's the cellular rim, it's a thick walled cavity, or it could be a necrotic tumor because it's just like if on the post contrast, there is this marginal enhancement that you said. The tumors which are aggressive, they can outgrow their blood supply, they can have areas of necrosis like here and there. Okay. So we agreed. I think we agreed that it's an aggressive process. Okay, aggressive process, and obviously you always put infection there. But in young people, you have to think about primary bone tumor. So I've shown you the first case when it was like permeative destruction in an adult, in a 60-year-old, and we said, okay, it's infection because it's involving two bones, but it could be metastases. Similarly, in younger adults, 25-year-old, you have to think about infection, yes, but it could be a primary bone tumor. So primary bone to anybody who is 40 or less, think about primary bone tumor, aggressive primary bone tumors. It can include lymphoma, but it can have Ewing sarcoma or even osteo as well sometimes, things like that, which is not ossified. But yeah, this was, I mean, it has to be biopsied. So the bottom line is when we are at a, uh, when we are at a crossroad and we are not sure that it's either infection or tumor, you have to biopsy it because that is paramount. And obviously, it has to be done in a bone tumor center or where you got a bone tumor surgeon, like sarcoma surgeon, because then you can plan the biopsy. So they say biopsy infection and culture tumor because they can mimic each other. All right. Okay. and you can't take a bet. You don't want to take ownership of this, that this is infection, and then sit on it, and then 3 months later, patient has got lung metastases, right? So,
Yeah.
so when you think about aggressive tumor, and you think it could be infection, it could be that, it has to be biopsied. Simple as that, right? So this was Ewing's sarcoma. But yeah, stick to your guns. Right? When you say aggressive, won't like Ewing is unlikely. No, you can't be. You can't say Ewing is unlikely. An aggressive process in somebody who is 30 or younger or 40 or younger. I know when you think about Ewing, you think about like 20-year-old or a 15-year-old, yes, but they can linger on up to 30s. All right. Or I mean, the other thing you could have thought about was, could it be giant cell tumor? Because you said it's going to subarticular, but it's not typical. It's got this necrosis and it's got this infiltrative pattern, and primarily it's metaphyseal rather than subarticular. The giant cell tumor would have been a pertinent DD probably, but unlikely. Okay, so that was this one. The first one, the other one you did well. So I think just, yeah. I mean, I've asked you on all of them, but just kind of stick to your guns. Right? Okay, so think about, don't say only infection. Infection is always there, but make sure that if you think that it could be a primary bone tumor or metastases, just put them on the top, because that's something as radiologists we don't want to miss. Infection will always be there, second or third, depending on the clinical condition or the picture or the age. And then, but always remember primary bone tumor in young adults and metastases in older adults. All right. Okay, great. Let's move to the second one. Sorry, we're probably.
Oh, I have one question in this
Yeah,
case.
please. Yeah, please go ahead. Yeah.
So like there was a lot of inflammatory changes which I was seeing on these study images in this case. So that because of that reason, I was like a little
So the
confused.
inflammatory change is, I mean, inflammatory change, when you say, I mean, obviously it looks like hyperintense because it's a cellular infiltrative process, but there was not much periostitis, isn't it? I mean, if you look at the post-contrast image, if I just go for the sake of discussion here, or rather I put this one, this is like a fat suppressed one. You see, if this was infection, where is periostitis? I mean, there's some subcutaneous edema, yes, I agree here.
Yeah.
But where is it? Over here, there's not much periostitis. So I know it's a mixed picture, right? But not everything that is bright is inflammatory.
Yeah. Okay.
You're just long Safran Spain, which is highlighting.
Yeah.
No, I agree. I mean, I think it's better to use the term marrow edema rather than inflammatory change. Because this could be infiltrated. MRI hasn't got the capability to kind of, for us to differentiate the edema, which is inflammatory, traumatic, or infiltrative. I mean, obviously, in the right context, you can make a call. If you see a fracture or something, obviously it's related to trauma. If you see an inflammatory lesion like osteosteoma or an abscess, you call it osteomyelitis. But it could be a necrotic tumor.
Okay.
So whenever the bottom line, if you're not sure, you have to biopsy.
Yeah. Thank you, sir.
So thank you. Okay, let's get the next one, please. Okay, you guys can. The next candidate is here.
Yes, sir, I'm here.
Or are we? My apologies for the connection. I think it might play up a bit. So, but we'll see how it goes. All right. So I've got a 10-year-old, and he's got a painful limb.
Sir, I cannot
see
see
the
your
screen?
screen. No, sir, I can't.
I have to share it every time. Do this. Yeah, you can see it now, please.
Yes, sir. Yes, sir, I can see it.
A 10-year-old with painful limb.
Okay. So I'm provided with the X-ray pelvis of a slightly immature patient, and the so he is presented with a painful limb. Visualize bones. They are grossly unremarkable, and I cannot see any periosteal reaction, and in the right femoral neck, I can appreciate that there is a rounded, lucent lesion noted in the neck of the femur, and बाकी rest of the bones appears to be unremarkable, and the bowel shadows and the soft tissues they appears to be unremarkable. So a lucent lesion in the femoral neck. Uh, with mild
Is it
surrounding sclerotic margins.
all right? Okay. So what does that
Uh,
imply?
Sir, that imply that there is some ongoing activity in this lucent lesion.
No, no. Okay. No, what you mean is that sclerotic rim implies there is ongoing activity. Is it an aggressive feature or a non-aggressive feature?
Sir, it is an aggressive lesion.
Okay. Why do you say that? We have seen two aggressive lesions, right, in the last candidate's kind of cases. You've
Yes.
seen two aggressive patterns. Does it look like that, or is it
No, sir.
different?
No, sir. No, sir. Sorry, it looks benign looking lesion.
Or a non-aggressive lesion?
A non-aggressive lesion, yes.
And why do we say that?
Because it has got a narrow zone of transition.
Excellent, right? Okay, so you can draw around it, right? There is a sclerotic rim, okay?
Yes,
So
sir.
it is a slow-growing or a non-aggressive lesion which is well-defined with a sclerotic rim.
Well-defined round.
This
Yes,
is a narrow zone of transition,
yes.
okay?
Narrow zone of transition, yes.
But this is a non-aggressive lesion, right? But still, location-wise, what do you put in your differential if you're reporting this X-ray in a 10-year-old boy?
So it can be yes, so it can be a simple bone cyst, or it can be osteoid osteoma or Brodie's abscess will be aggressive lesions. So I have to think
Depending on which stage we catch them on.
Sorry, sir.
So depending on which stage you catch them on, I mean, they can look. I mean, if it's a Brodie's abscess which has been like grumbling on, it's not in the acute phase, then it could be well defined.
So my differentials in this case would be a Brodie's abscess and osteoid osteoma.
Okay. So what will be the next step then?
Sir,
You would like to go for a nuclear bone scan, or would you like to go for an MRI?
sir, I would like to go for with an MRI.
Okay. You can see the screen?
No, sir.
Yeah. You can see it now, please?
Yes, sir, I can see it now.
Okay. This is like a coronal
Coronal stir images, and okay, so the lesion described on the radiograph is re-demonstrated, and it's a well-defined rounded to oval lesion seen in the femoral neck, and with no surrounding edematous changes seen, and mm, so so are the post-contrast images available? Because I cannot see any edema around it, or
Okay, I'll
it's
show
an
you a
error.
T1 image first, all right?
Okay.
So let's look at the T1.
Okay. So, sir, it is again showing a sclerotic rim with no surrounding periosteal reaction or marrow edema.
And what's the T1 signal?
So, it's low on T1.
Okay, so okay, I'm gonna put the post contrast for you guys. So if I put it this way, so this is post, this is plane. You guys can see the screen still?
Yes, sir, I can see it.
All right, okay. So you can see which one is post contrast and which one is pre, yeah?
No, sir. Okay, so this is the post contrast image. Yes, sir, this
These
is.
are axial oblique. This is T1 fat suppressed pre contrast, and this one on the right of the screen is post.
Sir, I can see only one image on my screen.
Yeah, it's so easy to have a separate screen. I mean, usually when I teach, I've got two screens, so it's just like I'm using. Wait, I'll wait. I'll put if I put this.
Sir, it is. I guess it is without contrast, right? The written at the top right corner.
Okay, what about now? You can see
No,
both?
yes, sir. Now I can see both. Yes, now I can see both.
Let's scroll now.
Okay, so I'm. So can you scroll it again? Sorry. So there is no definite post contrast enhancement that I can appreciate.
What do you mean? What do you mean by definite? So this is pre-contrast. This is
Yes, sir.
post-contrast. So you think there is enhancement or not?
So there is central enhancement. Yes. Yes.
Okay, let me put this one for you. This is a sagittal plane post-contrast.
Okay, so there is mark central enhancement, and I think it's it's a nidus of the osteoidostoma.
Okay. Right. Nidus of the osteoidostoma. So why there's not much reaction around it?
Sir, so it so it must be in the initial stage. I have no idea, sir.
I mean, the nidus is usually a small thing, isn't it? Right. I mean, this is
Yes.
just like the nidus will be in the center, and they'll be like sclerosis or inflammatory change around it. I mean, this is just a metaphysical. The one thing, I mean, the contrast is helping you is it a cyst or not?
So it's not a cyst.
Yeah. Okay. Okay, I'll show you the bone scan. You said osteoma. And let's see. So I'll magnify it for you guys. Just give me a second. Try to. So, what do you see on the bone scan? This is the frontal projection. This is the posterior projection.
Sir, sir, there is sir, in these images, I can see the symmetrical uptake of contrast in the epiphyses of the humerus, and then femur and wrist, and in the tibia.
Yeah. So you think this is osteoma or not?
Sir, if it would have been osteoidostoma, it would be a sort of a donut sign and intense uptake of central contrast.
Right. So what else could it be? Yeah, I can show you diffusion. I mean, you guys like diffusion, so let's just as a completion's sake.
Yes.
The child is well, actually. His blood tests are fine. So, I mean, Brody's abscess is something which is unlikely.
Yes, sir.
Let's just put. You guys can see both
Yes, sir.
images.
Yes, sir. I can see both images. Okay. So it is
all right. Yeah. Okay. So this is okay. Let me just window it. So this one is DWI and this is ADC.
so it is a hyper intense upon DWI, but not low on ADC. So there is no restricted diffusion.
Okay. So it's not a Brody's abscess. It's not
It's
an
not an
osteoma,
osteoidostoma.
not a cyst. What are we left with in a 10-year-old?
Sir, Langerhans LCH, Langerhans and histiocytosis.
Right. Okay, that's fine. Let's move on then. Next case for you. This is, let me see how old is he? He's a 40-year-old
Okay.
and he has got leg pain. Let me just magnify it probably. You can see the screen?
Yes, sir, I can see the screen.
Ruin it a bit. Right. Just describe what you see, please.
Okay, sir. X-ray leg, including knee and ankle joint of a skeletally mature patient, and this X-ray, I can appreciate that. So, so this seems to be a mild permeation along the femoral end, which I would like to confirm it on the X-ray of the thigh. And in the tibia, I can appreciate that there is a central.
Let's go back. Sorry, let me just stop you. You want to describe it more, like, because we have seen permeative things previously.
Yes, sir.
What would be a better way of describing it? You want to just reconsider and start again? Please.
Okay. Actually, the
Again,
screen
please.
was. Yes, it was not that clear.
You can see the X-ray or not?
Yes, sir, I can see it. And
Okay.
sir, the lower end of the femur seems to be mildly. Sir, I can say it's mildly sclerotic as
Yeah,
compared
so
with the.
that's a better way of saying it, isn't it? It's not
Oh,
it,
yes, sir.
permeative. We have seen permeative, but it's really kind of infiltrative, washed out, or there are multiple different size holes like moth-eaten. This is more sclerotic. It's heterogeneous. Yeah, you can. Heterogeneous is a good word, which will probably take you out of many situations, right?
Okay.
And there are like areas, predominantly it's areas of sclerosis, isn't it?
Yes, sir.
Can you see any sclerosis anywhere else on that image?
So in the lower end of the tibia, in the central in the metadiaphyseal region, I can see some ill-defined sclerosis, and in the lower end of the femur.
Okay, let me put this one there now. Okay, so you want
Okay.
to just kind of describe what you see there?
Yes, sir. Again, I can appreciate that there are mixed lytic sclerotic areas in the lower end of the femur, and central sclerosis without any endoscopic scalping in the lower end of the tibia.
Right. What else do you see on that lateral radiograph?
Uh, so subtle areas of sclerosis also seen at the upper end of the tibia as well, and I cannot.
You can
Yes,
see my arrow?
yes, sir, here.
You mean this one, yeah?
Yes, sir, these one.
Let's forget about that. Anything else?
Sir, other than the lower end of the femur and lower tibia, I cannot appreciate anything else. Soft tissue is so there is no periosteal reaction and no soft tissue.
Okay. What about the cortices?
So there is So the cortex of the fibula is fine, and I can appreciate that the anterior cortex of tibia is thickened.
Okay, so now let's go back to the AP. Right. You think it's a concordant finding, or is it just spurious on one view?
So the thickening of the cortex.
Yes.
So it is an important finding.
No, no, I mean, it is there on this view as well. It was just on the other view.
Yes, sir. I can now appreciate it in this view as well.
Right. Okay. So you've got three foci of abnormalities here, isn't it?
Yes, sir. Yes, sir.
Two in one bone and one in.
One in the
Okay.
femur and two in the tibia.
Okay. Yeah. So he's a 40-year-old and he's got leg pain. So what do you think? Can you put them together? Or is it, I mean, what, I just want to know what are you thinking about? What do you think? Is it something old, we can leave it be, or is it something we need to investigate further?
Sir, so the lower end of the femur needs to be investigated further. It looks to be an aggressive looking lesion, and
Like,
so
like what?
so it can be some metastases or leukemia, lymphoma. I would put these three differential for that.
What do you
And
think about sclerosis? Why, what that sclerosis, is it worrying or is it,
that
what
it
does
is
that
very
means?
so, so it is worrying. It can be that of metastatic origin, and
Okay. All right. So next step is MR, obviously, isn't it?
yes,
All right. Okay. Okay, let's start with, you want to see a coronal stir or T1? Your choice.
so I'll start with the coronal stir and then axial T1 if I will.
Okay. So I've got large field of view coronal stir of both
Yes.
legs. All right. And
Yes.
we have seen the X-ray of the left leg. Okay. So the scroll, this is like going from the back. That's your Achilles tendon at the bottom. All right. So
Yes.
going forward now. Okay, I put that, I think I'll leave that image for you. You can take
Yes.
your time and describe what you see. No need to rush. Just take your time.
Okay, so in this image, I can appreciate that on so, the on the left, the lower end of the femur, there are heterogeneous ultra mixed intensity signals are noted, and which are predominantly intramedullary and seen in the metadiaphyseal region and extending into the epiphysis as well. And then there are ultra MR signal intensity areas with marrow replacement noted in the upper end of the left tibia as well, with cortical thickening also noted in the left tibia. And on the right, there are heterogeneous diffuse altered marrow signals are noted involving the right uh, tibia, and with areas of cortical thickening. However, no definite cortical erosions are seen, and also there are changes of marrow replacement noted in the right tibia as well.
So let's
And
look at the T, right? Okay.
sorry, sir, your voice was not clear.
So like these are coronal T1 weighted images. All right. Okay. So let me scroll again for you. So what does that add to what you have said? Do you stick to your guns or are you going to change your mind, or what do you think? On just describe the T1 weighted images, please?
So again, there are geographic heterogeneous ultra MSK intensity areas, which I can appreciate along the lower end of the left hip femur, and without any cortical break or erosion, and rest of the findings are again similar. I can appreciate that there are changes of marrow replacement involving the right tibia and bilateral tibia, more so on the right side.
So we agree that there is marrow infiltration in
Yes,
both tibia, right?
yes, sir.
Okay. Uh,
Yeah, in the one on the on the left side lower, so they seems to me to be like bone infarcts or on the left.
right. So tibia we are happy with that there's an extensive marrow infiltrated process. What about the distal femur? You want to describe the T1 weighted images there?
Yes, yes, sir. There are geographical shape heterogeneous marrow signals, and they could represent infarcts.
Okay. What about the distal tibia hair? This area there?
Sir, this seems to be some sclerotic or so. Uh,
Okay. I think we are just delving in too much, right? Okay. So,
yes,
right. Can you, I mean, fair enough. I mean, this one looks more like geographical with areas of sclerosis that you have seen. But what is
yes.
this on T1? What is that right component to it? What are these areas
So
composed
these,
of?
sir, if it is bright on D1, it can be so it is marrow, normal marrow fat.
Yeah. Okay. So, so what you think? Can you put it together? What's your diagnosis then? What's happening?
So there is some marrow infiltration and marrow replacement with bone infarcts. Sir, can it be some hematopoietic disorder like sickle cell or
Okay, I mean, what's the predominant, what's the more worrying abnormality, the infarcts or the marrow infiltration?
infarcts are more worrisome?
Why is that? Right, okay. We are not talking about brain, right? Okay, I mean, bone marrow infarcts are like, I mean, this, you got areas of fat there as well. So there had been some process there, whether it's infiltrative or inflammatory, that has led to that area of bone to kind of have that healing response and probably some areas of dead bone, right? But
Yes,
for me, the more worrying thing is this extensive marrow infiltration in both tibia, right?
okay.
And if I put, I know I didn't show you this one, but I will put the post contrast axial for you. Just give me a second. Uh, okay, yeah, well, you guys like diffusion as well. So I mean, that's diffusion. Let's just, let's for the timing, let's forget the left side. We focus on the right tibia, right? Because it has to
Okay.
be the same process, isn't it? I
Yes.
mean, in real life, you have to come to one process that can explain the findings, right? So this is ADC map. What do you see here on the right, which you don't see on the left? So this is the left tibia. This is
Mm-hmm.
the right tibia on an ADC map. What do you see?
Well, on the right, I can see there is a more extensive disease process with involvement of the cortex and uh,
And
so it's basically, I think it is breaching the cortex at places on the right as well.
yeah, okay. So let's put, if I put this one,
It's basically infiltrating into the adjacent soft tissues as well on the right.
there you go.
And
So I'll put it there for you. You can see, let's focus on the right, right?
yes, sir. Yes, sir.
Right. Yeah, so this is thick enhancement around the tibia, isn't it? Yeah,
Yes, yes,
of
yes.
soft tissue.
Mhm.
We know the marrow is infiltrated on T1, right? Okay, and you got this donut which is wrapping around it. And is it restricting or not?
Sir, so these are DWI images, right?
This is ADC.
Yes, sir, it is restricting.
you want DWI, I can put DWI as well for you. You guys like
Yes, sir, it is restricting because it is hyperintense upon DWI and low on ADC. So
Yeah.
it
So what
is,
does that mean? We
sir,
have seen
it
one
means that
case.
yes, sir, it means it's a highly something that is highly cellular and
Correct.
um,
Okay. So let's finish it off, right? Go back to the T1. You got it in the fibula as well.
so
I mean, one thing, I mean, you think this is excessive, this is diffuse infiltration or just marrow infiltration?
so this is excessive. This is diffuse infiltration.
I think it just, look at the whole bone is
Yes, sir.
involved.
The
Okay.
whole bone is involved along with the destruction of the cortex extension into the soft tissues and
I mean, this is it typical for metastases to do that?
no, sir.
So what is it
Metastasis.
typical of?
Sir, 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 again, leukemia or lymphoma.
Good, excellent. So when you've got a large kind of segment of bone involved like this, extensive, right?
Extensive.
You
Yes.
think about hematopoietic malignancies, like
Yes.
leukemias in young people, and then kind of lymphoma in more adult, and then CLL and things you can think about in more adult kind of thing. But think about hematopoietic malignancies. Yeah, this was biopsied. It came back as B-cell lymphoma, right?
Okay.
So let's go back to the X-ray again. So I know it's a bit, it's not typical of I mean, lymphoma can do anything, right? Okay.
Yes.
But whenever you think about a long bone with air with doesn't look normal, and then you got areas of sclerosis, think about that these areas of sclerosis, could these be areas of infarction, right?
Okay.
Obviously, I was thinking that you would say in the distal femur, you think about osteosarcoma, there's a bone forming areas because there are sclerosis, right? So when there's sclerosis, I think there are two things you have to think about. Is it new bone formation or is it dead bone?
Okay, sir.
Right. Okay. And then you can kind of make a differential about it. But yeah, this was biopsied and it came back as lymphoma. Right. Okay. How many cases I've shown you? Two. All
Sir,
right. Okay.
two cases. Yes. Yes.
And last one for you then. Just a second. I don't know whether we have shown this case before. Not sure. Okay, let's go to this one. I think that's more. Okay, this one. So we have got a 19-year-old.
Okay, sir.
And I'm just letting the images come through. If, there we go. Yeah. So she came with leg pain and it's a DVT scan. And I'll just scroll through. Okay. So it's labeled. You can see what's happening. All right.
Yes, sir. Mm.
Okay. I
Okay.
think I'll put
So
this image.
it is the scan of the upper calf. Okay. Okay. It is labeled there. Yes.
Probably I'll put this one there for you. Right. Okay. So you are reporting this DVT scan done by a sonographer and you're reporting it. So what
Okay,
would
so
be?
I'm provided with a static image of ultrasound, Doppler image, and it in which I can appreciate that there is a normal blood flow seen in the shown vessel, and there are two large heterogeneous soft tissue intensity areas noted in the region of the popliteal fossa and in the upper calf, with areas of vascularity noted in them and mild vascularity, and these are well defined rounded areas and sorry,
I'll help you
I
further.
would like to compare these with the other limb and contralateral limb and
I'll show you this tiny loop. All right. So just bear with me. Just all of you keep looking on it. If you can see it moving.
yes, sir, I can see it. So it's a large lobulated heterogeneous soft tissue area in the basically in the muscular plane. And
Right. So what do you think? What you'll put in your differential?
mm,
She doesn't
sir,
have a D.
sorry, sir.
There's no DVT.
Yes, sir. There's no DVT. I'll ask about the history of the patient, about the presenting complaint and symptoms, and sir, sir, it could be some soft tissue lesion, but it's not showing. So it can be some
Mhm.
sarcoma or
Okay. So what you will suggest next?
sir, sir, first I will compare it to the contralateral limb, and then I will
Oh, it was just, sorry, okay, go back. I'll just go back to that second. All right, okay, let's look at this.
okay. I'll ask about any previous investigation from the
Yeah,
patient, and
so
then
the
I'll proceed.
patient had this X-ray done last week.
Okay. So again, in this X-ray, I can appreciate that there is a large heterogeneous looking soft tissue mass, which is seen in the popliteal fossa and posterior compartment, and uh, and the visualized bones appears to be unremarkable, and so it's a basically a large soft tissue mass in the region of the upper calf and the popliteal fossa, and now uh, I'll proceed with the MR.
So there's one important thing, important negative that you haven't mentioned on the
So
next.
the bones appears to be unremarkable, no joint involvement,
That's fine, but
and
what about the soft tissue mass? There is something which you can't, which you're not.
so there are no areas of calcification,
Right. Why
phleboliths,
is
or
that important?
so, I can rule out hemangioma or some vascular malformation.
Okay, good. All right. So what will be the next step? You do a CT or you do MR?
Also, I'll do an MR.
Right. Okay. So, okay, we can start with a T2 fat suppress then. You can see the image?
Yes, sir, I can see the image.
All right, okay. I'm just going to scroll it. So we're going up.
Okay, so okay, I can appreciate that there is a large lobulated at- heterogeneous ultra MR signal intensity mass lesion, which is seen in the posterior compartment of the leg, and it is not getting suppressed upon stereo images, and so the surrounding bones appears to be unremarkable, and it seems to be encasing the neurovascular bundle. And so I would like to see post-contrast images if available.
Okay, you want to see post contrast. So I've got it here, but I want to see if there's a pre contrast. Yeah, okay, I have it. Let me just put them side by side. Right, just a second. So this one is pre. This is pre, and I'll put the post contrast. That one.
Okay, so the first one is pre and the other one is post.
No, wait.
Okay.
Let me just put it together for you. Right frame of mind. Right frame. There we go. Right, and that's yeah.
Okay. Okay, so okay.
This one is this is post, right? Okay, I'll scroll
Yeah.
them, and then we'll
Okay.
see what we find.
Okay. Sir, sir, I cannot see the scrolled images. They are static. So I can see your cursor moving, but not the images. Yes, sir. Now the images are moving. Okay.
All right. No, I think there's a lag probably. Let's just start again. So you can see the image on the tibial tuberosity level, yeah?
Yes.
All right, going down,
Mm,
going up, sorry, going up.
okay, and going
So
down.
what do you see?
Sir, sir, I cannot appreciate any definite post-contrast enhancement.
Like there is no area of enhancement whatsoever?
No, sir, there is peripheral enhancement. Yes, peripheral enhancement is there.
What kind
Uh,
of peripheral enhancement?
Lobulated rim-like peripheral enhancement, but no central
Is it,
enhancement. I cannot.
wait. Is it rim-like or is it nodular?
It is nodular. Sorry, nodular.
Yeah, so that's a good word, isn't it? Yeah.
Yes, sir.
It's
Yes, sorry.
interrupted. It's not a
It is
continuous.
interrupted, non-continuous nodular enhancement,
Yeah.
and few subtle areas of central enhancement I can appreciate, but no, yes, nodular is peripheral
We can
enhancement.
look at another plane because sometimes changing the plane helps. Okay.
Okay.
So we can show you this one. But that gives you a better idea that
Yes, sir. So there is nodular peripheral discontinuous enhancement, and in
what
this,
does that mean? Is it a okay? Yeah, okay. So just describe and let's see what you make up of it.
sir, it's a lobulated lesion, soft tissue lesion, aggressive looking with
Is it a lesion or a mass?
so it is a mass.
Great. Okay, good. Yeah. When you see a big thing, anything on 3 centimeter in the lung is a mass, isn't it? Yeah.
Yes.
So I mean, this is a huge one, isn't it?
Yes.
This is
Sir,
and then what about the new neurovascular bundle?
sir, it is encased or pushed in.
So distally you can see it, right?
Yes.
That's your tibioperoneal trunk,
Yes,
right?
sir,
Okay.
yes.
As you go up,
As we go further, it is encased by this.
it's like
Yes.
slit-like. There's no
Yes.
plane, then it's gone.
It's gone. Yes, sir.
And then proximally it's there, right? Okay.
Yes.
So conclude and
Yes.
give me a differential, please.
Okay, sir. My differential would be, sir, peripheral nerve sheath tumor or there is some so peripheral nerve sheath tumor and sarcoma, and I would advise the biopsy of the lesion.
When you say peripheral nerve sheath tumor,
Mhm.
you mean like a schwannoma or a neurofibroma, is it?
Yes, sir.
Or there is some aggressive form of peripheral nerve sheath
Some
tumor.
malignant peripheral nerve sheath tumor service.
Okay, MPNST, right?
MPNST or sarcoma, and I'll advise the biopsy of the lesion.
Right. Any sarcoma in particular, if you want to be really clever radiologist?
Just synovial sarcoma because it is near the joint cavity.
Okay, it's nearer the joint, and what else is there? Is it enhancing solidly? What kind of enhancement is it showing?
The nodular interrupted enhancement.
So yeah, excellent. I mean, this is a sarcoma, right? And it's next to the joint, right? So synovial sarcoma. It's not going. I mean, the question is it going in the joint? I think it is kind of next to the capsule.
Yes, sir. It is
Okay.
touching. Yes, sir. I'm working it. It is also crossing the mildly crossing the joint as well.
Well, it is just kind of hitting just at the back of it, right? Okay.
Yes,
So
sir.
probably,
Yes.
yeah, that's your PCL, you see? So that's the PCL there. It's just sitting next to the PCL. So I think it's
yes.
highly likely it's not the joint, right? There's no effusion, but at the back, this is the posterior meniscus. This is the posterior horn of the meniscus, see? It's just there. So it's probably, there is intra-articular extension as well. So yeah, but I mean, synovial sarcoma doesn't have to have intra-articular extension. They are just
Yes, sir.
next to the joint. If they get really big, they can get into the joint. Okay, and about 20% of them don't enhance.
Okay. Okay. Sir.
So a lack of enhancement does not mean. I mean, obviously, you imply it could be a necrotic tumor, but this doesn't look like necrosis, isn't it? It doesn't look like fluids kind of thing. But remember, if you got a big mass next to the joint, it's not enhancing as well. Think about synovial sarcoma. If it has got calcification in it, not the phleboliths, But like linear amorphous kind of calcification, you can always think about synovial sarcoma as well. Okay.
Okay, sir.
Okay. So what will the next step then?
So biopsy.
Supposing you think it's a sarcoma, what will be the next step?
Sir, I'll refer it to sarcoma center for biopsy.
Right. You think this is salvage? This is a salvageable condition. The limb can be salvaged or not?
Sir, I'll discuss it in MDT, and
Yes.
we'll get the joint above it and below it, but I don't think so. It's salvageable the way it is involving the neurovascular bundle.
Excellent, right? So the neurovascular bundle is encased, right? So
Yes.
if you want to save it, I mean, you can't. It'll be like you can't resect it. I mean,
Yes.
you'll have to leave a cuff of tumor around the neurovascular bundle, right?
Yes.
Okay, so the chances are this patient needs to have an above the amputation.
Yes.
Okay. All right, great. Any questions? And then we
Sir,
move on
what
to
was the first case? Sir,
I don't know.
Okay. Okay.
I mean, the patient had a nuclear scan. We did a leukoscan scan. It was all negative. So probably it was LCH, but it was a small lesion, and the patient probably, I mean, he didn't return, so we don't know. But you sometime I just showed you the just for practice that there can be these small lesions as well, which are not a cyst, which doesn't look very inflammatory. It's probably something in the healing phase and the bird. Yeah. So probably it could be LCH. I mean, LCH can behave like anything.
Okay, sir.
All right. Okay.
Anything.
Great.
Yes, sir. Yes.
Okay.
Thank you, sir. Thank you.
Thank you. All right. Okay. Let's get the last one then. And I am going to get the next case for you then. Right. Ready? Right, next case is here. Yeah. Next patient. Sorry. Next patient is. I'm sorry. Next patient. Next. Next candidate is there. Sorry.
Assalamu alaikum, sir.
Walaikum salam. Sorry to keep you late, but yeah. Okay. So this one is a 50-year-old lady, and she has got a lump on the medial aspect of her ankle. I'm just showing you the ultrasound. Let's just scroll through and then. Okay, well, you're seeing quite a lot of images there, but let's just focus on this. So there is this image.
Okay, sir.
And then on the medial aspect of the left ankle, and this is the Doppler one. So how would you describe and what you are going to do next?
So this is a color Doppler ultrasound of the ankle on the medial aspect, and it shows a heterogeneously hypoechoic lesion, which is in close contact with either some tendon or a vessel, and it is showing significant internal vascularity. Whereas neurovascular bundles are seen just beneath it. Considering the well-defined hypoechoic lesion with significant internal vascularity, and this could be a vascular tumor like hemangioma. The other possibility could be of a neurovascular neurogenic tumor. This is what I can.
Okay, so let's go for the MR then, yeah?
Okay, sir.
Okay, let me show you the MR. I think I'm going to start with, for a change, let's start with the T1 weighted, all right? Okay.
Okay, sir.
So that's the ankle. You want to describe what you see?
Yes, sir. And this is the T1 weighted image of the foot and the ankle, in which I can appreciate a well-defined hypo-intense lesion. on the medial aspect of the ankle joint within the subcutaneous tissues, and it has well-defined margins with no evidence of any adjacent fat stranding. The overlying skin appears normal, so the appearance are more of a benign-looking lesion. There is some hyper-intense signals in the lower part, may be artifactual, as I can appreciate that these signals are extending outside of the territory of the region. Would like to look at the other images, other
Okay,
sequences.
let's get the
This is the stir sequence.
No, wait, I'll get it for you. Just
Okay,
a sec.
okay, sir.
So yeah, this is a PD fat suppressed. Okay.
Okay, so it appears bright on PD fat set, so it doesn't suggest that it is a fat containing lesion, slightly a cystic lesion with internal
Say it again.
septations.
Sorry, say it again. What did you say?
So it is not a fat containing lesion.
Okay.
And it was also hypo-intense on T1, which also suggests that it's a fluid containing lesion with some internal septations.
Okay. Did it look like fluid on ultrasound?
No, sir,
Then
it was not.
yeah. So you want to
so-
take that statement back?
So can I just have a look on post-contrast T1 and
Right. Okay. Yeah. Okay. This is post contrast.
so it is significantly enhancing
Wait.
lesion.
Wait. Just a second. I'll put the pre contrast as well. I think it's always good practice to put
Yes,
pre
sir.
and post together, and you can subtract it if your technician has got that. You can ask your technician; they can give you subtraction. I don't have subtraction here, but that's something you guys can start doing probably. But yeah, so this one, like, okay, we've got it now. So this is pre, this is post. You can see both.
Mm,
You can see both, yeah.
and so the right one is the pre-contrast.
Yeah, yeah. No, this is post.
This
The
is
right
post.
of the skin. You can see my arrow.
Okay,
Yeah. So this is post. This is pre. So
and the first one is
is it cyst
pre-contrast.
or is it solid? Yeah, this is pre. This is post.
So it is not significantly enhancing. It is appearing hyper on both.
It is, yes, but it's a bit more on the other one.
It doesn't look like a cyst, and it was neither a cyst looking structure on the ultrasound as well.
Yeah. Okay. So, what do we think it is then?
There is still like a hemangioma, maybe, or
What do you think about this structure there? This structure there. Is it just a fat strand or is it some fascia?
it's a tendon.
No, I mean this line. You see that fine line?
Okay.
So this lesion is kind of sitting on top of it, isn't it?
It's a fascia, hypointense line.
So it's kind of based on the fascia, isn't it?
Yes, it looks like a facial plane, which appears hypointense.
So the lesion, you've got a solid lesion based on the fascia in the medial aspect of the ankle. So what's your differential? You gave a differential.
So the differentials are the neurogenic tumor. This could be a vascular slow flow blood like venous blood containing structure, venous hemangioma, and this can also be
like hemangioma on MRI.
What's that?
Do you think it has got flow voids or it has got phleboliths or it
No,
has
sir,
got
no.
thrombus?
I cannot appreciate any flow void. Although I can appreciate few internal hypointense areas which are likely the septations, or these could be the fine internal vessels even, but not looking like the flow voids.
Okay, if I say this patient had this lump for 5 years, what would be your differential? I'm going to close it. I'm going to get the next case for you. And you just tell me. And that's a real thing. It's the patient had it for 5 years, but now it's getting more noticeable, and she wanted it out. So what can last that long for? Do you want to change your differential or stay with it, or can it still be a sarcoma?
Can it be?
Can it still be a sarcoma?
So since 5 years, sarcoma cannot be there. It would have increased in size and would have metastasized till.
It's unlikely, but you never say never. Yeah, okay, but yeah.
A low-grade sarcoma.
Sorry, say it again.
Sir, such a silent sarcoma is less likely.
Right, okay.
I
Fair
cannot
enough.
think of any other thing, because even the ganglion cyst would not give such appearance.
Okay. Fair enough. So what else could it be? Could it be a schwannoma? Could it be an F-sheet tumor?
Yes, sir. That I just told in my differentials. This could be a neurogenic tumor, could be a schwannoma.
Okay.
Be a
So would you still biopsy it?
Yes, sir.
Okay. All right. Yeah, it was biopsied. It came back as a schwannoma. Yeah. All right. Okay. So yeah, so schwannomas, I mean, you always see them around. I mean, in the spine, you see ancient schwannomas in the presacral space, which sometimes they can calcify, sometimes they can have fatty change. So schwannomas are slow-growing tumors, and if they are not related to a major nerve, they can stay there for a long time. And this one was, as you can see, this was more towards the subcutaneous area, so it was more probably some kind of cutaneous branch or something rather than the tibial nerve or the plantar nerves. All right, okay, so yeah, that's fine. All right, let's move on to this one. This is a 30-year-old, and he's got dull shoulder pain, atraumatic. I'm going to start with the MRI, and we got axial PD fat suppressed. Okay, wait, I'm just going to scroll now. Let's just look at it, and then you can describe any abnormality that you see. So that's the top AC joint going down.
Okay, sir. And this is the axial PD fat set image of the shoulder, in which I can appreciate that there is a hyperintense lobulated lesion which is insinuating within the deltoid muscle and is also in I think continuity with the neurovascular bundle. I can also appreciate a few internal hypointense foci within it, which could be the areas of the calcification or the hemorrhage. Considering the lobulated appearance, this could be a hemangioma with internal phleboliths. The other possibility again could be of a neurogenic tumor giving the target sign appearance.
Sorry, let me show you a T1 before we jump to okay, probably T1. I've got an axial if I can find. Yeah, okay. You got a T1 weighted image. Let's just go a bit bigger. So describe the findings on T1 for me.
So on T1 weighted images, the same lesion is showing internal areas, internal hyperintense areas and few hypointense rounded areas. And the hyperintense foci could be the hemorrhagic or could be some high protein content, even could be the fat contents. For that, I would like to look at the fat sat images.
Okay, I'll show you the fat suppressed images. That's just for our learning. We have seen it before, but let's just put them side by side. Okay, let's just make it together. You can see both images, or
Yes, sir. It is showing the signals are being suppressed on, and the areas that were appearing hyper on T1 are being suppressed on FATSAT images, which suggests that these are the fat areas. And this is the post contrast T1 FATSAT images, so it is also showing significant enhancement. Considering the internal.
I don't have I haven't shown you a post contrast.
Okay, okay, sir.
So you want to see a post contrast. So this is pre, and I have got a post contrast here. Okay, let's just start from like just let's just look at the images first for all of us, and you can. So this is the post contrast.
Okay, sir.
The pre contrast is on the left. Okay.
So the lesion is showing enhancement, significant enhancement on post-contrast images with signal suppression of the areas that are
enhancement or filling?
Enhancement or what?
Or filling?
It is a filling. Okay, this could be a fill-in of the contrast within it.
Yeah, I know. I mean, it's a difficult one, right? Okay, because I mean, these are like cavities.
So considering the fat-containing areas as well as the hypointense areas, this could be hemangioma with the fatty component and the phleboliths. The other possibility could be of the liposarcoma, as it is an enhancing and as it is showing enhancement. And
Okay,
it is kind of ill-defined with no capsule.
Right. I'm just trying to find if I've got a T2 weighted. I don't have a T2 weighted image there, but I've got a gradient echo. Let me see if I can find it, and then because I mean fat, it could be fat or it could be, like you said, high proteinaceous.
Yes, sir.
Fluids. Or
but that proteinaceous fluid would not suppress on FATSAT.
Right. Well, I mean, we don't know. Is it suppression or is it just T2 hypointensity? Yeah.
Yeah, this could be this.
I'll put the gradient echo for you, and I think I'm gonna put.
There are areas of the.
Yeah, just a second. Let me just put them side by side so that we are a bit sure what we're talking about. All right. Okay. So there we go. So I've got a fat suppressed on this side, and I've got a gradient echo on the other side. So what do you think? These areas which are suppressing.
So these fat suppressed are T2 FATSAT, right?
Yes, that's correct.
Okay, fine. And on T2 FATSAT, these are low. To confirm the real fat saturation, for that we need to compare T1 and T1 post FATSAT. So these could be the areas of the calcification within the lesion on T2 weighted images, and they are showing blooming artifact on grease sequence or susceptibility weighted images.
All right, okay, there we go. I think I've got the thing that you were asking for. So I've got a plain T1 on the right, and
Okay,
I've got
sir.
a T1 fat suppressed on the left. Yeah.
Okay, sir.
Okay, so let's see.
So they are still bright. They are not being suppressed on FATSAT, T1 FATSAT images.
What are these then? What are these bright areas then?
So these are and these are hemorrhage.
Excellent, great. Okay, so you see, so yeah, that's just applying the basics there, right? Okay, so you got phleboliths.
Yes, sir.
You have got blood clots.
Yes,
Okay,
sir.
so these are thrombi.
So this is yes, sir. So this is likely a venous hemangioma.
No, don't call it hemangioma. Just say a venous.
Okay, vascular tumor with internal phleboliths and the areas
Don't
of
call
the
it
thrombus.
vascular tumor. Don't call it vascular
Okay.
tumor. Vascular
Then, sir.
tumor. When we say vascular tumor, we are thinking about angiosarcomas, hemangioendotheliomas, things like these kind of things, right? These are vascular malformations.
Vascular malformations.
And
Okay,
because we are seeing venous lakes with thrombi, with phleboliths, so this is a slow flow venous malformation, you can call it, right?
Okay, sir.
Okay.
So,
And then how do we, is there anything else you would, I mean, if you're reporting this, would you like to see something else just to add to your confidence?
sir, X-ray to look for the confirmation of the phleboliths.
Yeah. So there we go. So that's hopefully bullets
So
look like.
there are phleboliths for. So
Okay.
hence,
This one, if I show you this one, if I had started from there, I mean, okay, on this view, I mean, you could have thought that this is probably synovial osteochondromatosis. I mean, some of you
yes,
can.
sir. Yes,
Yeah.
sir.
But it's quite further away. The joint usually finishes here, right? Joint capsule usually finishes there.
Yes,
It's a
sir.
bit closer to that. And obviously on the lateral, it's easy. It's kind of far off. But yeah. Okay. All right. Last case then. I've shown you, this is the second one, right? Okay. The last one I'm going to get for you now. Just give me a second. Okay. Yeah. Okay, let's just change a bit of a scene now, and I'm going to put this one. Oh, let me start with this one. So I've got a 27-year-old,
Yes, sir.
and he presented to ER with generalized weakness and inability to walk.
Okay,
That's
sir.
the X-ray you have.
So this is X-ray cervical spine lateral projection, in which I can appreciate that there is almost complete destruction of C3 vertebral body, with some superior end plate irregularity of C4. And there is a subtle increase in the prevertebral soft tissue thickness. So some lucency is also appreciated in the region of the destruction, which may represent the air within some collection. So this is likely an infective process which is causing the destruction of the vertebra. The differentials include the osteomyelitis, eosinophilic granuloma. The other possibility could be of a metastatic deposit. However, I can appreciate that the posterior elements are intact. No destruction of the posterior elements is noted. For further, I would like to have the MR of the patient, contrast enhanced MRI of the cervical spine for further evaluation.
Right. Okay. Well, the patient was unwell, so we couldn't do the MR that night. So we said we'll do a CT. All right.
Okay,
So
sir.
I'm going to, we did a CTPA actually because he was quite hypoxic. All right. So we did, I'm going to show you the sagittal reformats of the CT. Yeah. Okay. So that just, I think it's probably bone even, or no, it's just soft tissue window. I think. Yeah. But he didn't have a PE. Okay, let's go through the other side. So if I stop there, you want to
Yes, sir.
describe the findings?
Yes, sir. There is the involvement of the multiple bones during this call. I can appreciate that there is involvement of the upper thoracic vertebrae as well as likely the lower thoracic, D12 or D11. And there is also the involvement of posterior elements and the ribs of the patient, with likely some soft tissue component that is extending in the prevertebral space as well as the epidural space. Until now, I
See the
have.
axials?
Yes, sir.
Let me just change this to soft tissue. Okay, let me put it to lung windows. You want to say something about
Yes.
anything you've seen?
So the findings are still the same. The destruction of the bones, ribs, vertebrae, with soft tissue component that is extending into the prevertebral space and also likely infiltrating the pleura.
Mhm. Okay, so let's look at the lung
There,
windows, right?
there are also, yes, sir.
Let me just show you the lung windows then, all right? Okay. Anything you want to comment about?
Yes, so there were soft tissue nodules in the right upper lobe, which were also in close contact with the um, uh, likely infiltrating the right paratracheal region, causing compression over the trachea, which is displaced towards the slightly displaced towards the contralateral side, and are also in close contact with the upper lobe vessels.
Right, okay. So
this is likely a metastatic disease process.
right, in a 25-year-old?
Yes, sir, could be because of
Okay, let's
any.
do the MR. No, we're going to the MR now. Right, so you said get an MR. So we managed to get the MR the next day because the spinal surgeon wanted it before they can do anything, as they always do, right? Okay, so it's not splitting. Okay, there we go. I think that's like a T2 weighted. I'll show you the lower end as well in a second, but you've seen the CT.
Yes, sir.
This is the MR, just a plain T2 weighted sagittal parasagittal images. I'll just magnify it for you there. You want to just kind of describe the findings?
Yes, sir. Yes, sir. This is a T2 weighted sagittal image, which is showing that there is an heterogeneously hyperintense soft tissue area in the previously described region, likely the mid-thoracic. I can even count it. There is also the destruction of C3 vertebra, and 4, 5, 6, 7, 8, T1. T2, T3, T4, T5 vertebral bodies, with prevertebral as well as the epidural component, which is extending to the anterior epidural space, causing slight compression over the cord. However, no significant abnormal signals are seen within the cord.
If you are reporting this MRI on your list without
sir.
any previous imaging, what will be the next thing you're going to do?
So would
Okay, we'll come back to that. I'm going to show you the bottom end, or because whole spine we have to do. So let's see if I got a sagittal T2 of the, that's there, I think. Okay, so that's the lumbosacral spine.
yes, sir. There is involvement of the sacral bones, posterior elements of L3 vertebral body, and there are also the abnormal signals in
Okay,
D12.
let me, you want to see post contrast or you want to see a T1 weighted? Your choice.
It's a post contrast.
Really?
Yes, sir.
I would have gone for a T1. Okay, this is
But
post contrast. Right, fair enough.
on
That's
post
fine.
contrast, there is central necrosis with peripheral enhancement. So these are likely the collections. Collections with the destruction of the vertebrae. So this is a disseminated infective process. Considering these large collections, the TB comes on the top, as there is more destruction of the bones and as compared to the bones, less involvement of the intervertebral disc, although they are involved, but to a lesser extent than the bone. For further evaluation, the patient would require this CS from these abscesses.
Okay. So what
These
about
can,
the
this are the other possibility, considering that there is also the involvement of the posterior elements. These could be even the necrotic metastatic deposits. I cannot completely rule out as the posterior elements are not the predominant feature of the tuberculosis.
So sorry, I missed that. The last point. What were you saying?
So as involvement of the posterior elements is more a feature of metastasis rather than the tuberculosis.
Okay. But what about this subligamentous contiguous abscess? Is that a feature of?
That is a feature of tuberculosis.
So you think the patient has got two concomitant diseases? Is it?
No, so the TB can be devastating. It can involve the posterior elements as well, but mostly in continuity with the involvement of the vertebrae, and then through the contiguous infection can involve the posterior elements. So
Right.
keeping this
I'm going to
appearance.
just show you. Sorry, I'm interrupting you, but I'm just going to show you the CT again. And there was
okay,
one more finding that
CT chest.
we'll mention. Just a second, because I think that's just a useful learning point. So I'll put it on bone window. So if I show you it,
Yes, it is looking like a collection.
so if I want you to focus on this, I think this is T. Okay, there we go. So what do you think about these lesions? Do they look like metastases to you? These round lesions.
Surrounded lesion with central hyperdensity.
Yeah, what's that central hyperdensity then? Is it
Could be a
calcification
sequestrum.
of a bit of
So
bone?
could be a sequestrum. Could be a sequestrum.
Yeah, okay, could be sequestrum or could be just, I mean, yeah, a bit of calcification or probably residual bone, right? Okay. So yeah, so that's very.
So this is tuberculosis.
Yeah. I mean, the MR picture is quite like it immediately kind of with the like without without thinking much, you knew that this is like Pox disease, isn't it?
Yes,
Because
sir.
this kind of subligamentous kind of abscess with multiple osteolysis, bone destruction, vertebral plana. I know it's extensive, and these lesions, they got calcification in it. So they say tuberculous abscesses can have calcification. I know
Yes,
it's a gross example. We biopsied it. It was malignancy was ruled out, and then yeah, it was the TB PCR positive and all that stuff. So I think it came back as TB, right? Okay, so that was that. But the question which I was asking on the MR, if you are reporting this C-spine MR on your outpatient list just for neck pain,
yes, sir.
let's forget about the upper thoracic. Let's look at the C-spine.
So there's significant compression over the cervical cord.
Yeah. So what will you do when you see this?
So urgent referral to the neurology team for the.
So how will you ensure that?
So I have to convey the findings to the referrer.
Yeah. So yeah, you pick up the phone and you call them, isn't it? Yeah.
Yes, sir.
Yeah, so that's that. Okay, I'm gonna just. I know we're over the time, but I just want to show one more case. Anybody can take it. You want to take it? Anybody else wants to take it? I don't have any
So I
problem
can
with that. I'm
continue.
just going to show you something. You can continue. All right. Okay. Just a second. Yeah. Okay. Right. So I had this child on my own call, and I was called by the pediatric registrar that this patient, they are suspecting he has got meningitis, and they want to do an LP. See my screen?
Yes, sir. Now I can see it.
So well, I was in the middle of a trauma scan, and they said, yeah, we got this child, we need a CT, and we need to rule out any space occupying lesion and to rule out increased ICP and all that stuff, right? Okay, I said, okay, fair enough, that's fine. Okay, so then we did this CT, and I'm just gonna scroll through the images, and then let's see whether we can spot something. Anything obvious?
So there was bit crowding in the region of foramen magnum, likely the tonsillar herniation.
Okay. So it's always a good
No,
habit
that's
to
it.
look at the other plane, isn't it? So especially the coronal and the sagittal. So I'll show you the sagittal first.
So
Just a second, I will get a better one. There's a better one. There's a post contrast active. We did a post contrast. That's So you want to say something?
So there is some enhancing lesion in the within the roof of the fourth ventricle, or
The roof is here.
there is something enhancing I saw.
Okay. That's not
So can I
projecting.
just
Yeah, let's just I want to show you all of you just what I. Okay, let's just look at the sagittal again, and focusing in the posterior fossa, obviously. Yeah, anything on that image that makes you worried?
there again some herniation of the tonsils and bit of the cerebellum below the foramen magnum,
Right. What about the
but
brain?
not that much significant enough.
Okay. Okay, let's look at the coronal.
So I
I think
cannot just figure it out.
I know it's subtle, but I just want to just we'll get to it. Don't worry. All right. Okay. So let's look at the coronal. If I put that image, I don't know how it's projecting on your side. You see any asymmetry?
Yes, you said there is some elevation of the tentorium on the right side.
Okay. Keep looking. What lives under the tentorium? Okay, it's too late. I mean, like
Oh,
I know
sorry.
it's no, that's fine. It just I don't know how it's not projecting that well.
So
I mean,
sorry. I'm really sorry.
no, it's all right. It's quite late at night anyway. So Right. I mean, the one thing that I want you, all of you, to appreciate, like you said, there's some tonsillar herniation here. Okay. There's crowding, right? But
Yes,
the
sir.
thing that for me, I mean, it just sometimes God just helps you, and you just kind of, it just, something is not right. I mean, you look at that brain stem, it looks a bit flattened.
Yes, sir.
See?
It is looking, sir.
Right.
There is flattening of the even
See,
bones, and
it
as well
looks
as the
like there is
compression
some
over
flattening here, isn't
the
it?
medulla as well.
Yeah, so that's something it didn't look right to me. All right, okay. And then we look at the post contrast. I'll put the axial. Where is the axial post contrast? I don't have a post contrast. Axial, I this bone. All right, I can change the lender color. That's bony lender. But okay, let's just look at this one. So this is post contrast. So this was I mean, I'll just go, let's see. There we go. So you see, there is some more foveal enhancement in the left
Yes, sir.
cerebellum.
Yes,
You
sir.
see, although you can note there's asymmetric foveal enhancement of the right cerebellar hemisphere.
Yes, sir.
When I saw that, and then we go back
Is
to
this
this.
Lehermitid across?
No, it's not that. It's not. Well, I know it looks like a tigeroid kind of appearance, right? But I think now you can see there. All of you can appreciate.
Yes,
Look
sir.
at the medulla, how it's flattened out against the clivus and against the tectorial membrane, right?
Yes, sir.
So this was just, and then when I was looking on the right side, there, you see that?
Yes, sir.
Something there is not right. So I have to pick up when you see this, and they're about to doing an LP. So you have to pick up the phone and
Yes,
say
sir.
that don't do LP, right?
Because it is
And
going to
then, yeah,
aggravate it.
that's gonna suck it down further, and
Yes,
then
sir.
you're in trouble. So this is another kind of thing when you have to just kind of pick up the phone. So there is, I think it's useful to do an CT before they do LP. So next morning they did this MR, and you can see that he's got this kind of a mass lesion there, like inflammatory probably. I mean, they thought it's probably infected cerebellitis. That's what they thought.
Okay.
Not we used to see these with COVID, like hemorrhagic cerebellitis and all that, but kids can get it. And yeah, this is like just that, but this is causing that mass effect. So yeah, so I just wanted to show you that sometimes, I mean, these are the few things that you have to pick up the phone for, right?
Yes,
Okay.
sir.
Great. Okay. Any
Thank you, sir.
questions before we? I know it's a bit. My apologies. It's a bit static because my internet was not that great, but I hope there were a few useful points that I managed to get across.
Thank you so much.
Any questions? I'm happy to answer. I can't see the chat. I can see the chats, but the chats are about like 71 messages, so I probably might not be able to get to that. Anybody? I mean, the floor is open, so anybody wants to ask any question, I'm here.
Yes, Dr. Asad, I can read the questions. There is one question. Please briefly findings between a difference between the pyogenic and tuberculous spondylodiscitis. Somebody's asking.
Well, that you need to read yourself.
Yes.
I mean, this is a very bad question, right? Okay, so it's yeah. I mean, the main difference I think is that usually pyogenic is more like it involves the discs and then gets into the bone. All right, and the tuberculous usually it starts in the bone and then gets kind of gets spreads again below the ligament, right? The one we have seen, the bone was gone, the discs were there, and then there was all this kind of collection. So I think these are the two. And in pyogenic, usually the disc is like the disc has got fluid or has got enhancement, and there is just an end plate kind of inflammatory changes or destruction. So I think usually pyogenic doesn't have that many collections unless it's been festering for a long time or patient is immunocompromised. So I think these are the two things. But sometimes, I mean, but with this extensive thing, if it was pyogenic, that patient would be really septic. He need probably inotrops or something. So yeah, again, I mean, for me, if I see contiguous multi-level involvement with subligamentous collections, so that's probably cold abscesses. And if there's just predominant disc kind of like the spondylodiscitis, then I think about pyogenic. I mean, that's it. But I think there was a good paper by Stuart Curry from Leeds about like 10 years back when I was a final year registrar. That's a useful paper. It was in ClinRad. You can read that. It's got good examples. But I think that's the only tip I can give you, that if you see the disc spared and a lot of bony destruction and subligamentous spread, then that's usually tuberculosis. If the disc is involved and primarily a disc-based disease, then probably it's pyogenic.
Yeah, that is very comprehensive. And there are a lot of people sending thank you comments. There's one question, what is the management of calcific tendonitis?
Right, okay. So yeah, so if it's around the shoulder, I mean, most of the time, I mean, that's the commonest place, I mean, where it presents. And usually what happens is, this is hydroxyapatite calcium. And then that can kind of extrude into the bursa, or sometimes I've seen it can extrude into the muscle belly itself as well. And it causes a lot of inflammatory response. It's like a chemical inflammation. So usually patient presents, I've seen patients crying with pain, like they couldn't sleep for 3-4 days, getting IM diclofenac in the outside facilities. And in the acute phase, what you do is you just give them steroid injection in the bursa, because that's where the inflammation is, right? And then after the acute phase settle down, 4 to 6 weeks, you can go and you can needle the calcium. You can even kind of break it with saline and suck it. We call it barbotage. But like in this case, this patient was like, he was in so much pain, but he didn't want any injection. He just said, okay, I'll just take anti-inflammatories, and then it settled down. So, but they are very painful conditions, particularly around the shoulder. I mean, the commonest is, like you said, somebody said in the supra, but you can have it in the infra, you can have it in the subscap. In the wrist, you can have it in the FCR or FCU. You can also have it in the gluteal tendons, like trochanteric bursitis area. So the gluteus medius and usually medius tendon, you can have some calcification there. And that can also cause severe trochanteric bursitis. And again, in that situation, you can give a steroid injection. But they are extremely painful condition, acutely painful, atraumatic condition with a very kind of little raised inflammatory markers, but usually they're like just 20 or 30, not more than 50. That's it, yeah. And I mean, sometimes if they're really chunky, like if they're big calcification, like 2 to 3 centimeter, and they're solid and you can't break it with a needle, then sometimes they have to go in and scoop it out with a small incision, and under fluoroscopic guidance, they can take it out.
Okay, thank you so much. Yeah, I think those were the questions, and everybody is saying thank you. They want more lectures from you. So thank you so much for the fantastic session and very well chosen cases, Dr. Asad, and for the patients and valuable tips for the 2B viva. And they were incredibly helpful. And I believe all the candidates are now feeling much more prepared. Hope to see you again soon. Thank you so much. And for all the participants, please fill out the feedback form, give suggestions and comments too. You will get the participation certificates, and the comments and suggestions will be very helpful for the future sessions. Thank you so much. Thank you so much, Dr. Asad. Thank you very much.
All right. Good night. Take care. Bye-bye.